Right, well, welcome everyone. I'm Kathy Reback, and I am the director of the CHIPTS Combination Prevention Corps. As the CHIPTS Combination Prevention Corps director, I am honored and very fortunate to work with many esteemed investigators in the field of HIV. Today, a few of the CHIPTS investigators are bringing to you our second In Case You Missed It webinar. Our first In Case You Missed It webinar was in August 2022, and that webinar focused on highlights from the International AIDS Society Conference. Based on the success and the popularity of the first webinar, today we are bringing you key highlights from CROI, the Conference on Retroviruses and Opportunistic Infections. And since we cannot all be in one place at the same time, we are dependent on these investigators to give us the highlights. If you have any questions regarding the presentations, please post your questions in chat, and we will get to as many as possible during the question and answer session at the very end of the presentation, with the exception of Dr. Harawa's presentation. Dr. Harawa has to leave early, so we will take questions related to her presentation first, then we will move on to the others. And our first presenter is Dr. Naina Harawa. Dr. Naina Harawa is a professor of medicine and epidemiology at UCLA who specializes in public health and health services research on HIV, STIs, substance use, and access to related health care. As director of the CHIPTS Policy Impact Corps at UCLA, Dr. Harawa co-leads CHIPTS' effort to help researchers inform policy decision makers about ending the U.S. epidemics of HIV, STIs, and hepatitis C. I will turn it over to Dr. Harawa.
Good afternoon, everyone, and I'm happy to be here. I probably have more content than I do time, so I will probably rush through a couple of these slides, but hope to cover the main points. The first presentation I want to talk about was called Digital Technologies for Supporting Adherence. It was by a researcher by the name of Lisa Hightower-Wiedemann, who's now at Florida State University in Tallahassee. Next slide. So it was really fascinating to me to hear how many different technologies we've had over time to both monitor and support adherence, what is to come, and I hear a little bit about the benefits and the limitations of each of these. Probably one that many of you are most familiar with is called MEMS caps, and that is literally a cap that goes on top of a pill bottle, and that indicates when it's opened as a way of tracking when and whether someone takes their information. These were a nice advance, but they had the disadvantage in that the information was stored locally, and it meant that somebody had to come back with their pill bottle and their cap in order to upload the information. So there was no real-time processing. There is the second generation of these, which I'll talk about next, and then go back to SMS. And EAMs, I'm sorry for using that acronym, but it's electronic adherence monitors. And these are like MEMS caps in that they track when containers have been opened, but they're full containers and they allow for information to be uploaded directly to the cloud. These were certainly an advantage in that they allowed for real-time tracking of adherence, but they can be clunky, call attention to themselves, and have not shown consistent evidence of benefit. Another thing that she described was just the use of basic texting interventions to help encourage people to take their medication, and maybe sometimes for people to report whether or not they had taken their medication. She actually argued this should probably be a standard of care, as WHO has recommended. It's very feasible to scale up, and it has been shown to have moderate benefits, but tends to be short-term benefits. Like many different reminders you might have on your phone, after a while, we tend to ignore them. And then finally, at least on this list, are smart pill packaging technologies like boxes, bags, blister packages that register every time one is open and a pill is taken out. Next slide. There are also bioingestible sensors, and I'll talk about those shortly. There's video observed therapy options, which is similar to directly observed therapy, but can be done over video. There are many different mobile apps that have been developed. Several have shown evidence of success, in terms of encouraging adherence. And then there's digital games that people have used, as well as avatars and chatbots. Some of these are very creative in terms of ways to measure and encourage adherence. Next slide. So a bioingestible sensor is much like what somebody might think. It's a sensor that actually becomes part of a pill. Once the pill gets broken down by the stomach acid, it relays a message to a wearable device that the user has, and then that can be relayed to a cloud-based server. So this is definitely making sure that not only is the package open, the pill is getting into individuals, but of course there's definitely ethical concerns about this type of an option, and she described several of them, including concerns about autonomy and data ownership. Next slide. And then just briefly, there's some interesting things to come. Of course, the use of AI, which we've all been hearing about, that could aid in detection of non-adherence and provide tailored support when somebody might be going into a non-adherent period. Wearable sensors. There's devices on the market that people may want to look for themselves or their patients that are digital dispensers. And then what you see up in the right is actually a social adherence robot that's designed to encourage adherence. Next slide. And so I'm now going to go on to the next talk. If you could keep going to the next talk, which was by Sunil Solomon. And he talked about what we still need to know about PrEP. And the main part I'm going to emphasize, next slide, is the importance of research on people who use injection drugs, because he pointed out that this is really completely missing. And the most powerful slide he shared was this one, which shows the two major trials of LA-CAB, each of which had about 4,000 people, or together had about 8,000 people in them. And together there were about 100 new infections identified in the two arms. Next slide. But at that same period of time, he was following a cohort of people who use injection drugs in New Delhi. And there were almost 160 new infections in that much smaller cohort of just 800 people. So a cohort of 1/10 the size had twice as the number of new infections. So this is the population that needs things like LAIs. You can keep going. There is some evidence that they're acceptable for some people who use injection drugs and for others not. But I think, as we know, for any type of prevention options, we need to give people options, and different things will work for different people or may work at different times for the same person. We can keep going. And then he talked about missing data, other populations that we also need to focus on, and research that needs to be done. So we'll keep going to the last talk, and then I'll take questions, because I really want to make sure I get a chance to cover this, which is restrictions on reproductive rights and how they will impact people living with HIV. This was led by Denise Jemison, the head of OBGYN at Emory. And she went through several scenarios based on composites of patients, or similar to patients, but not actual patients, of people living with HIV who needed abortion care, but were not able to get it. In this particular case, you had a 17-year-old who would have, when she was first detected, would have been allowed to get an abortion, but because she had to go through these different procedures consistent with Georgia law, by the time that she went for that abortion, there was a heartbeat detected and she was no longer eligible to get one. And then the next scenario, next slide. The next scenario involves a patient who was out of care, had a very low T cells and very high viral load. She presented to care because she has symptoms that were diagnosed as cryptococcal meningitis, but she was also found to be pregnant at that same time. Unfortunately, the recommended treatments involve two drugs, one of which is known to be teratogenic in rats, meaning it can cause malformation in rats and that therefore considered not safe for women to take during their pregnancy. And in Oklahoma, where this particular patient was, abortion was only allowed in order to save the life of the pregnant person in a medical emergency. And there was concerns whether or not this was sufficiently urgent to be considered a medical emergency. So you can see how this puts individuals in very difficult positions. Dr. Jemison also pointed out that cancer is another situation in which this comes up. There are many, many cancer treatments that are not recommended during pregnancy, and about 1 in 1,000 pregnancies do involve cancer. And so now women who are in states with restrictive abortion policies or other pregnant people will have very difficult decisions to make if they become pregnant. So I will just end with the last slide in which she talked about things that all of us can do if we're concerned about this, including supporting research in this area, conducting research in this area, supporting programs to train people to be able to provide abortions, and supporting both reproductive rights and addressing disparities and promoting equity. Because especially when you consider that many of these bans overlap with states that lack Medicaid expansion, sort of the problems with them grow in this setting of both poverty and lack of medical care. So with that, I will end and see if I have time for a couple questions.
Thank you, Dr. Harawa, for that excellent recaps. There's one question specific to you. It says, does LA Art do away with these monitoring technologies? How would we track an every other month shot? Would we need to?
So I think probably one of the other presenters may address that a little bit more, but if somebody is going to, the same provider, then you can just track through their medical records, whether or not someone needs the shot. And I think that is one of the benefits of LAIs. But as actually, I think it may have been Sunil pointed out, there are populations that are highly mobile. And so then they would need to go to different providers to receive these shots, and it becomes harder to track. And so we need advances in technologies and more interoperable medical records so that you can track people even if they're going to one provider after another.
Great, thank you. I know you have to hop off early. So we are now going to move to our next presenter, Dr. Alex Dubov. Dr. Alex Dubov is an associate professor at Loma Linda University School of Behavioral Health. His research includes studying patient preferences to improve the design and implementation of HIV prevention programs. Currently, he leads studies to increase the uptake of PrEP in coordination with substance use treatment in emergency departments and community pharmacies.
Thank you so much. And so we can go to next slide. I wanted to highlight a couple of studies related to lenacapavir. It's a long-acting new antiretroviral that can be taken every 6 months and can be combined with a pair of broadly neutralized antibodies to construct a complete twice-yearly regimen, according to the study presented. The reason why I was interested in this new antiretroviral because my university is one of the sites for studying this particular drug. So in this presentation, the takeaway was that 90% of study participants enrolled in this trial who received injections with lenacapavir plus infusions of broadly neutralizing antibodies. The two specific ones, they remained undetectable for over 6 months after stopping their existing antiretroviral treatment. So lenacapavir from Gilead Sciences is a long-acting capsid inhibitor. So it disrupts the cone-shaped trail surrounding the viral genetic material and sexual enzymes of the virus. Because it works differently from existing drugs, it remains active against viruses that developed resistance to other antiretroviral classes. It has long half-life, low potential drug-on-drug interaction, and it administered subcutaneously every 6 months. In earlier Calibrate trial, it showed potential for to be a long-acting treatment, but currently there are no other drugs to combine to be administered during that long window of 6 months. And so early research suggested that broadly neutralizing antibodies can be or might have a potential for HIV prevention in long-term remission, but they are prone to resistance, so they would be better in combination with other regimens. So in this lenacapavir would be a good combination for broadly neutralizing antibodies. And so next slide, please. So in the trial, it was one phase 1b clinical trial. They enrolled 21 people with HIV who were on antiretroviral therapy with viral suppression for at least 18 months, and they had a current CD4 count above 500 and had never had a CD4 count below 350. All participants were all but 3 participants were men, and the majority were white. The median age was 44 years. And they had been diagnosed with HIV for a median of 8 years and on antiretroviral therapy for a median of 2.6 years. And so the treatment, as I said, showed potential for viral suppression for 6 months. 18 out of 20 patients, they maintained viral suppression for 26 weeks after 1 injection and infusion of broadly neutralized antibodies. There was only mild grade 1 injection site reaction. It was the treatment was safe and well tolerated. And so the takeaway from this study would be that this potential regimen may enable a complete twice-yearly HIV treatment. Next slide, please. There were another presentation on the same agent, but using as a long-acting HIV prevention regimen. And so this is only a study in the macaque model with the same agent. And the researchers suggested that in the macaque model, the protection was achieved following single dose of lenacapavir, and it was mentioned that lenacapavir in macaques is 4-fold less potent against HIV challenged as an equivalent in human exposure to HIV. Out of 11 animals, 8 were protected, 3 were infected, but among those infected, they didn't develop resistance to lenacapavir. And as a follow-up, there's 2 large phase 3 purpose studies evaluating lenacapavir for PrEP, and they currently enrolling subjects. There are also another presentations on another long-acting modes of prevention. It's a refillable implant lasting several years with islatravir, and another one with biodegradable implants, which is also both of them showed protection in macaque models. So that's on long-acting new treatments. Next slide, please. This study isolating the effect of COVID-19 related disruptions in HIV diagnosis in the US. The team from CDC, they noticed that between 2015 to 2019, new diagnosis of HIV infections in the US, they were decreasing at a steady rate of about 2% per year. Then there was a drop in new infections in 2020 by 17%. And the reason for the study was to understand what caused this huge drop in new HIV infections. Was it due to COVID disruptions in testing services, or was it due to social distancing? So fewer persons needed testing. And so to understand that, the team studied past infections, trends in infections from 2010 to 2019, trying to understand the pattern, how many infections should have been diagnosed based on prior patterns, but were not. They called it excess misdiagnosis. And they used 3 statistical methods to estimate 2020 excess misdiagnosis for each HIV transmission group. They also looked by gender, ethnicity, and race, and by 4 US regions. Next slide. Next, please. The team suggested, the research team from CDC suggested that there were about 3,238 diagnoses missed, or 18% of expected diagnoses were missed in 2020. These misdiagnoses were not attributable to incidence change in HIV, but to disruption in testing services. By number, the largest groups with largest number of misdiagnoses were males in birth, men who have sex with men. You can see the numbers, how many diagnoses were missed in these particular groups. Persons in the South and Black persons. So this is the largest number of missed HIV diagnoses by groups. By a proportion of misdiagnosis, the largest proportion of missed HIV diagnoses were among Latinx persons, 22%, females at birth, 24%, heterosexual persons, 24%, and men who have sex with men and inject drugs, 30% of misdiagnosis. This is the highest proportions, not number. And so in the conclusion, the researchers reminded that there is longer time to diagnosis for HIV infections. So it's important to increase efforts to test people as a part of AHE efforts and prioritize populations according to the findings in this study. Next, please. One other study I wanted to highlight, I was focusing on DoxyPEP among people with or at risk of HIV. And researchers wanted to identify DoxyPEP prescribing strategies that would maximize overall doxy use while maximizing the impact of on STIs to help inform implementation of DoxyPEP. And the methods they used was a study of electronic health records of more than 10,000 patients accessing care at Fenway Health. It's the largest, one of the largest providers specialized in care for sexual and gender minorities. They explored 10 hypothetical DoxyPEP prescribing strategies. Some strategies would prescribe DoxyPEP to specific patient groups, for example, PrEP users, so people with HIV. Other strategies would prescribe DoxyPEP to patients following one or more STI diagnoses, for example, rectal STI diagnosis, or after 2 STI diagnoses within 12 months. So they evaluated these prescribing strategies by retrospectively examining STI testing data from 2015 to 2020. And they assumed that DoxyPEP would have been prescribed and used when patients met this criteria for these hypothetical scenarios, and that STI incidence would have been reduced by efficacy estimates from previous clinical trials. And so overall, their main finding was that prescribing DoxyPEP for 12 months at a time to people with STI diagnosis could avert 42% of subsequent STIs. Next slide, please. So they found that strategies that involved prescribing DoxyPEP for 12 months following STI diagnosis would be more efficient than prescribing DoxyPEP to specific groups of people, for example, PrEP users or people with HIV. That is to say that fewer people would need to be prescribed DoxyPEP to prevent the same number of STIs. The potential impact and the efficiency of prescribing strategies varied across STIs. So, for instance, in one strategy, prescribing DoxyPEP to people diagnosed with syphilis could avert up to 25 of subsequent syphilis infections, with only 9% of all people needing to use DoxyPEP. They also found that if DoxyPEP were prescribed following an STI diagnosis, it would have a similar efficiency among people with HIV, PrEP users and non-PrEP users, suggesting that restricting DoxyPEP to subgroups of people with STIs may not be warranted. So their finding may inform clinical guidelines for DoxyPEP, balancing benefits and harms of use. And they suggest that most efficient strategies would be based on STI history rather than groups of people who use DoxyPEP. Next slide. The final presentation I wanted to highlight, it's a study of 8-year pooled analysis, adherence in HIV incidence in 6,000 women on PrEP. And the researchers suggested that adherence matters. So to study this, they looked at the real-world effectiveness and adherence to PrEP among cisgendered women enrolled in all PrEP demonstration trials. So the subset of women participating in all the 11 PrEP demonstration projects in 6 countries over 8 years. So they included 6,296 women and found that overall efficacy of PrEP, looked at the overall efficacy of PrEP and adherence among a subset of women who had data on adherence to PrEP. There were 2 groups of women, or 2 types of adherence. One was objective adherence measured by concentration of PrEP and dried blood spots and plasma. And there was a subjective adherence in a larger group reported by pill counts, electronic pill caps, monitoring, and self-report. Next. So the median age of participants was 23 years old. They had 0.7 years of follow-up in the studies. 78% they were from Africa, 21% from Asia. 32 women acquired HIV, so effectiveness of PrEP was 0.72 per 100 patient years. Age was inversely associated with HIV incidence. Higher infection rates were among married women or those who had no children. The adherence efficacy relationship for PrEP was comparable among women, comparable to similar studies among men who have sex with men. Adherence among women, 17%, they found different groups of adherence. 17% of all women were highly adherent, 22% were consistently moderately adherent, 39% had moderate and declining adherence, and 21% had consistently low adherence. Women under 25 years old were more likely to remain highly adherent than those under 18. Over half of all participants didn't use PrEP consistently, and so one of the main highlights of the study was importance for additional prevention options for such as long-acting PrEP for women. Thank you. That's all I had to highlight.
Hi, am I next or?
I will introduce you. I'm sorry, I was muted.
Well, I was actually thinking it would be, since we talked about PEP already and mine are about different things, we could flip order and you could let Rafi go next and talk about PEP.
No, we're gonna maintain the order. Okay, so our next presenter is Dr. Pamina Gorbach. Dr. Gorbach is a professor in the Department of Epidemiology in the Fielding School of Public Health and the Division of Infectious Diseases in the David Geffen School of Medicine at UCLA. She focuses on the biobehavioral epidemiology of infectious disease, especially how HIV transmission, acquisition, and progression is affected by substance use. Dr. Gorbach collaborates with many CHIPTS investigators on the research and training here in Los Angeles, as well as in global settings. Dr. Gorbach, we turn it over to you.
Okay. So my slides aren't as nice as Alex. I'll go quickly. Let's go to the next one. So I'm going to talk about partner services for people who inject drugs, that's PWID, to identify partners living with HIV and HCV. Let's go to the next one and I'll come back to the thing at the end. So basically this was a study that was conducted in 8 sites in Africa, where what they did was they found people who were actively injecting and living with HIV, and then tried, those were considered their index partners, and then used partner services, which has actually not been done very much in Africa, to try to find their partners, get them tested for HIV and HCV, and then followed them up 6 months later to see where people were and how they were doing. So next slide, please. That's the basic study design. So they had 989 indexes. Those were the people that injected drugs and were living with HIV that they started with, and they were about split male and female. Big point here is just to know that only about 67% were suppressed, and that there was a big overlap in those also doing transactional sex and injecting drug use. Next slide, please. And so this is how they did overall. And as you can see, when they found partners, if you look at the second If you look at the blue boxes, you can see that they had partners that were sexual only, partners that were injection sexual, and then partners that were injection only. And as you went down through this, what they ended up with partners were about 25% that were HIV positive as well in the sexual only. And the highest HIV prevalence was among those that were injection and sexual partners. And then about the same number that were injection only in terms of HIV. For HCV, by far the highest number of those of the partners that had HCV positive were those that were injection only, although those injection sexual close, much lower for sexual only. Next slide, please. So then they did a cascade for HIV and HCV. Let's skip to the next slide because I think I'll show you where we are. Here's where what's called the NNTI, which is the number needed to treat to get them. And so what they found is among all the partners, this is the number of people that they needed to interview in order to find people that were living with HIV or with HCV. Okay, so the next slide, please. And here's what they did with the follow-up. And I thought this was sort of the critical point here. So at enrollment among the indexes, as we said, about 19% were not on ARVs. But at the 6-month follow-up, that dropped a little bit to 13%. Overall, they lost about 14%. If you looked at the partners in terms of not on ART at baseline, it was 23%, and that dropped to only 12% by 6-month follow-up. And overall, they had about 16% that were lost. So it was a pretty, next slide, please, effective way to do that. They also looked at IPV, which is interpersonal violence, and found that, people were concerned that if you find partners, there would be repercussions if you were having them tested for HIV and they found out that they were positive. But there was not anything found in terms of IPV from the effect. Okay, next slide, please. So they found a very high rate of partner location. Somebody asked where it was done. This was all done in Kenya. They found 97% of the partners, which I just think is absolutely remarkable. So that's why I'm presenting this, because 97% were found. That is really incredible. They used peer educators to do it. It can be done. So you can find partners of people living with HIV, it's sexual partners, injecting partners in Kenya. So I think this is really remarkable. And that, most of them, particularly the injecting partners, knew their status, but many were not on ARP or virally suppressed, and they did make an improvement there, and there were no social or adverse outcomes. So that's that. Next slide, please. That's the end of that one. So the next thing, we're going to jump, back here to the United States, and I'm going to show you an analysis that was done looking at HIV time-space cluster detection and how that's used to look for outbreaks among people who inject drugs in MSM. And so this looked at the data over time and looked at differences in areas comparing the alerts for people who inject drugs and MSM. So let's go to the next slide. So here's the way they do this typically. So this is what CDC does, which I thought this was interesting to sort of understand their process. So they look at HIV diagnoses that were reported to the surveillance systems quarterly for each county, and then look at the number of diagnoses during the previous 12 months for MSM and PWIDs separately, and then compare them to the mean from the preceding 36 months. And that's how they see if there's a sudden increase. So you can see in this drawing here how they have the prior periods, and here they have an A, B, and C, and they look at the total number of diagnoses, and so that represents the 36 months. And then they look at the recent 12 months for changes. And then they have counties stratified by urban-rural classification, and that's how they do it. Okay, next slide, please. So then here's the results basically for this particular analysis. And what we can see is that during 2018 to 2021, the alerts among MSM occurred in about 3 times as many counties as among the PWIDs. And that there was a difference in the geographic distribution if you look at it. So in other words, the large metro centers had most of the PWIDs. Whereas I thought this was interesting, counties alerts with MSM were considered fringe metro, large fringe metro. I'm not quite sure what that is, but and then what they call medium metro. So they weren't the same big, dense, large cities as the others. But if you look at the top row, you can see that the counties with alerts among MSM over this period of time that spanned COVID, there were many more among MSM than among PWID. Okay, next slide. And this is just looking at the temporal trends. And on the left, you can see the same thing. There's this increase among the MSM in terms of the alerts than there were among the PWIDs. That the subsequent alerts are more common, though, among PWID than among MSM by type of alert. So this is what divides it over on the right. Next slide, please. So the occurrence of alerts among PWID in nearly half of the large metro areas is concerning, is what they said, which definitely points to the fact that when we look at people who inject drugs, it's happening in big, large cities and in the central areas of those cities. That they did see a decrease near the start of COVID-19. And as we've seen in other presentations, it's probably because there was HIV testing. But then these alerts recovered among MSM and surpassed the pre-pandemic level. So now we're seeing increases among MSM in these alerts in terms of the numbers identified with HIV. I think that's the main finding from this. Next slide. Okay. So now I'm going to switch gears totally and talk a little bit about monkeypox. This is the only one that I'm going to present to you about monkeypox because I found it really powerful. So what we're going to see here is this is a international collaboration from 18 countries that contributed data from people living with HIV who were identified and confirmed with Mpox between May 11th and December 24th, 2022. What's critical about this particular study is these are all people living with HIV with CD4 counts below 350. Okay, and so this is what the sad situation is when you find people who with uncontrolled HIV who develop Mpox. Next slide, please. And I'm going to save you because I did not include any of the truly sad and horrific images that this presentation included of what happens to people living with HIV when they develop Mpox and they're not virally suppressed. But this particular study had 19 countries involved. There was only one from Africa, but it was mostly 10 from Europe and 8 from the Americas. Next slide, please. This is called the ShareNet sites. And so these were the Mpox criteria. They had it at any site. They were all adults. And as I said, these were people living with HIV that had very low CD4 count below 350, or what they called CDC stage C disease. These are the structured case reports they use. Next slide, please. So bottom line is most of these were cisgen men. And as we said, they were previously diagnosed with HIV. Those who had been previously on, 91% had been previously diagnosed with HIV. About 60 had been on ARV at one point, but 30% were diagnosed HIV, but not on ARV or non-adherent, 30%. And you can see the distribution of CD4 cell here, and it's really pretty striking. You know, the inclusion criteria for the study was below 350, but if you look, they really dropped, and in fact, they had 85 that were below 100. Here's what the viral loads were. And then in terms of concurrent opportunistic infections, and if anyone had been vaccinated prior, so there were about 8% with a concurrent opportunistic infection, so not very many. And in terms of being vaccinated for smallpox pre-20, that was only 4%. And those who had been vaccinated, very few, only 7%. Next slide, please. So I think for time, the bottom line is here. There was a difference in mortality stratified by CD4 count. And as you can see, the red boxes are those who died, and those who in the side on the left is by CD4 count, and on the right is by viral load. Obviously, those that had the low CD4 count and the viral loads were those that were most likely to die. And those that had higher CD4 counts and in fact had undetectable virus, you did not see deaths over there on the far right. Next slide, please. Keep going. We're going to skip the complications. So the bottom line is the deaths, and this is again just the distribution of how the deaths were that occurred. So they had 27 deaths in this particular study that were identified, and of these, those that 27 were those below CD4 count of 200 there. So that was pretty obvious that the lower the CD4 count, the more likely they are to die. And the next slide. Here it is, keep going. We'll skip some of these details. Bottom line is all 27 deaths occurred in people with CD4 counts that were below 200. So even among those, remember inclusion criteria is below 350, but all the deaths were in those below 200. The mortality rate was 15% in those with CD4 count below 200, 27% in those with CD4 count below 100. So I think that's the main point of this, that the implications is that, Mpox among people living with HIV that don't have controlled virus is where we will see the deaths. And so there's really a need to prioritize access to Mpox antivirals and vaccines in countries that don't have access to that. And as I said, the last slide, I think, is just an acknowledgement of the participants and the families of people who were deceased. That data was presented here and all the contributing sites. And then this manuscript was published subsequently in the Lancet. And that's it.
Thank you, Dr. Gorbach. And we are now moving to Dr. Landovitz. Our last presenter today is Dr. Raphael Landovitz. Dr. Landovitz is a professor of medicine in the Division of Infectious Diseases at the UCLA David Geffen School of Medicine. He is also the director of the UCLA Center for Clinical AIDS Research and Education, CARE, and the CHIPTS Center co-director, as well as the co-director of the Combination Prevention Corps at CHIPTS. Dr. Landovitz is a global leader in both HIV treatment and HIV prevention clinical trials. He has led combination prevention intervention studies using PEP and PrEP strategies for MSM and trans women, and notably has led the DAIDS-funded clinical trials evaluating long-acting injectable cabotegravir for PrEP. In sum, Dr. Landovitz is one singular sensation.
Thanks, Dr. Reback. That was a nice Broadway reference. Thank you. Please don't be terrified that there are 7 abstracts on here. We're going to fly. Okay, next slide, please. So first thing I'm going to cover is something that Dr. Dubov referenced, just to make sure everyone's on the same page. Doxycycline for STI prevention, also called DoxyPEP. This is a strategy that first came to prominence. Let's move to the next slide. When Jean-Michel Molina in 2015 conducted a study that was a sub-study of his IPERGAY study. So on the left side of this slide, you'll see the results of his study. What he did is he took people who were taking on-demand PrEP and a subset of them and randomized them to either doxycycline at a dose of 200 milligrams after condomless sex within 72 hours of that sex event, or no intervention. It was an open label study, and the primary outcome of interest were bacterial sexually transmitted infections. And what he found was an overall reduction in STIs globally, about a 47% reduction in all STIs, but it turns out it was limited to syphilis and chlamydia. So the syphilis, there's a 73% reduction and a 70% reduction in chlamydia, and there was no reduction in gonorrhea. And the presumed mechanism of that lack of activity against gonorrhea was high levels of doxycycline resistance in Europe in gonorrheal species. So that got a lot of attention appropriately, since we're in the middle of an STI pandemic. And fast forward to this past summer at the AIDS 22 conference on the right side of the slide, Annie Lutkemeyer presented an abstract of a 2-site US-based study, San Francisco and Seattle, where they did the same thing. These are cis men and trans women. This particular study had 2 cohorts, people who had HIV and also people who were HIV negative and were on PrEP. And they looked at the same 3 outcomes, gonorrhea, chlamydia, and syphilis. And long story short, there were statistically significant large reductions in all 3 STIs in the individuals randomized to the doxycycline intervention compared to the control intervention, including a 55% reduction in gonorrhea. Again, sort of a fascinating finding and presumed to be attributable to the fact that there's more doxycycline sensitive gonorrhea in the US. Now we'll get to the CROI abstracts. Next slide. So the first study, there was a lot about this at CROI. In my estimation, it was sort of the most interesting stuff at CROI. So Dr. Lukemeyer, who presented that study that I just referenced from AIDS 2022, presented some follow-up data from that study. The study's name was DoxyPEP. So people call the intervention DoxyPEP. It's also the specific name of this study. What this tried to answer was what happens to the resistance of other bacteria that are in your body when you take doxycycline for post-exposure prophylaxis for STI prevention. And they looked at three things. They looked at, does it affect Staph aureus, which is a common skin and mucosal bacteria that live on our bodies, and what happens to other species of the bacteria genus called Neisseria, of which gonorrhea is a member. So the full name of gonorrhea is Neisseria gonorrhoeae, and there are other Neisseria species that live in our body and don't cause disease. And the long story short is really there was no effect on rates of colonization nor antibiotic resistance in the other Neisseria species. That's good news. And with the Staph aureus, it turns out, when you take doxycycline, there's less Staph aureus on your body, and that's probably a good thing. Where there was just something to put a pin in, a note, is there was a slight increase, an 8% increase in doxycycline resistance for the Staph aureus that remained. Remember, there was less of it, but the one that was lamed, there was an absolute 8% increase in doxycycline resistance. So we're going to put a pin in that, and it probably needs longer term follow-up. There wasn't enough data to say if it had any effect on gonorrhea itself in terms of inducing resistance. Next slide. So these were their conclusions. And the reason I put this up is because it sort of sums up sort of where we are. We need longer term information and monitoring for resistance and other potential complications, including effects on the bacteria that live in our intestines called the microbiome. But this is a really interesting and important intervention. And in fact, San Francisco Department of Public Health has put out guidelines for its use. They're the first group to do so. Next slide. So just when you thought 2 studies was good, how about a third study? And this third study was actually a factorially designed study. This was cis men and trans women in France. It's this same team that did the Ipergay study that I mentioned at the very beginning. It was what they did is they randomized people to DoxyPEP or no DoxyPEP, and also to a vaccination with a meningitis vaccine that is designed against a specific bacteria called Neisseria meningitidis type B, which is a bacteria of the same genus that gonorrhea is in that causes, it's one of the bacteria that causes meningococcal meningitis. It's a very rarely used vaccine. The most common Neisseria vaccine that is used to prevent meningitis is against other non-B type strains, A, C, Y, and W. So this is a less commonly administered vaccine. It is approved by the FDA for meningitis prevention, but there are some observational data that suggests that it's also active against gonorrhea. And the observational data suggested that it's between 25 and 50% protective against gonorrhea. So this study was designed not only to additionally evaluate DoxyPEP, but also to look at this meningitis B vaccine for gonorrhea prevention. So next slide. So the study was stopped early. This had been announced in January. This is sort of, the study was stopped early, and the Data Safety Monitoring Board that was overseeing it said, stop everything and give both interventions to everyone, meaning they both worked. What we didn't know before CROI was the details. Next slide. Here are the details. So this is each individual STI DoxyPEP versus no DoxyPEP. On the left, chlamydia trachomatis, 89% reduction if you got the DoxyPEP compared to not. On the right side of the slide, syphilis, 79% reduction DoxyPEP versus no DoxyPEP. I'm a believer. I don't know about you. Let's move on to the next slide. Okay, gonorrhea on the left. Now remember, this is in France, where the first study of DoxyPEP showed no effect on gonorrhea. It was only the one in the US sites that showed an effect on gonorrhea. But here, 51% statistically significant reduction in gonorrhea. And on the right side is a bacteria that we don't talk about quite as much, called Mycobacterium genitalium, also had a 45% reduction in the DoxyPEP compared to the no DoxyPEP arm. So this is now the third study showing high levels of efficacy against these bacterial STIs in this particular population of cis men and trans women. So really, really exciting. Next slide. And here are the results of the meningitis B vaccine arm. So 51% reduction in first onset of a gonorrheal infection in people who got the meningitis B vaccine compared to people who didn't get it. So that's really exciting. And there are a number of other studies that are continuing to evaluate this meningitis B vaccine, both in cis men and trans women and also cis women, in a number of other contexts globally. So much more to come about this, but this is the first time we have a randomized controlled trial that is showing an efficacy signal for this vaccine for gonorrhea prevention. So this is practice changing, this whole set of studies. Next. So just when you were all set to put in the chat, what about the cis women with vaginal exposure and DoxyPEP? You didn't say anything about that. Oh, wait. So there was a study, it was called the DPEP study. It was done in Kenya. And this was HIV negative women who were on daily oral PrEP. And they were randomized to DoxyPEP versus no DoxyPEP. Next slide. And this was perhaps the biggest disappointment of the entire conference, is there was a high rate of STIs all around, and there was no effect on any of the STIs. Now, nobody knows exactly why this is. There was a pharmacokinetics presentation that accompanied this that suggested the drug does get into the female genital tract at high levels, and it should work. So the question, of course, is adherence. Did people take it? God knows. This feels a lot like the early PrEP data, where people said that daily oral tenofovir-based PrEP could not work in women, could not work for vaginal exposure. And the real question is, how can you support women in using it appropriately? Not that it doesn't work. And so we don't have good biomarkers of adherence. We had self-report only, which of course is an unreliable measure, and everybody said they took it just fine. And the question came up of, well, can you look at the PrEP adherence? And people said, yes, well, we sort of looked at that. There were no incident HIV infections. So clearly they were taking their PrEP. But my argument is, if you're taking a daily oral intervention, doesn't necessarily mean that you're able to take an on-demand post-coital intervention. So I think there's a lot more to be learned about this. And unfortunately, this data does not support current use of this for vaginal exposures. So let's move on from there. Okay, so I'm going to move on to data on long-acting injectable pre-exposure prophylaxis. One of the more talked about presentations was data from the HPTN-084 study, which was one of the randomized trials that led to the regulatory approvals of cabotegravir. This is the one that was done in the global south in cisgender women that showed an 89% reduction in overall HIV incidence in women randomized to cabotegravir compared to TDF-FTC. And the question that this study tried to answer is, in COVID, there were a lot of delayed injections in this study. So what were the pharmacokinetics telling us in the women who had delayed injections? And the long story short, I'll save you trying to decipher this data-heavy slide, is that you got concentrations in plasma that were anticipated to be protective with sort of a 4 to 6 week delay in injections. So really what that ended up being is you occasionally should be able to extend the dosing interval in cis women from the recommended 8 weeks out to 12 weeks. This does not mean that you can routinely dose it every 3 months, but probably protective efficacy is maintained out to 12 weeks for an occasional missed injection. So that it's important to sort of contextualize this appropriately. This does not mean go out and prescribe this every 3 months to everybody. And you cannot extrapolate these data to individuals born male. So this is for individuals born female only. Next slide. So the other piece of data that I'm going to sort of breeze through was from the 083 study. And this was a study that Sue Eshelman, who leads the HPTN Laboratory Center, did from the 083 data, looking at what acute or primary HIV infection looks like when you break through long-acting cabotegravir PrEP. And she's dubbed this LEVI as opposed to acute HIV infection. LEVI stands for long-acting early viral inhibition, and it's clinically very distinct from classic acute or primary HIV infection. And the table on the right, and we can share these slides later because I want to leave time for questions, that it's really different from primary HIV infection and is a distinct clinical syndrome. So something to think about in the clinical management of people who break through cabotegravir PrEP. And the last study I'm going to talk about, actually two really quickly. Monica Gandhi at UCSF presented a pilot project of giving long-acting injectable ART, so long-acting injectable treatment, to people with HIV in the Ward 86 clinic who were not virologically suppressed. This is really important because this is a non-FDA approved indication. The FDA approval requires that you be undetectable before using long-acting injectable agents. And she, in the population that she gave this to, there were 59 people who were viremic, meaning they were not virally suppressed, and 57 of them were able to be suppressed in this way. So that's really impressive. And the question is that generalizable, and what are the consequences when it goes sideways? So stay tuned for more about this. This was kind of a nuclear presentation. This does not mean go out there and do it, but it sort of is provocative and indicates when we need more study. And the last study is this. People always ask, all this long-acting injectable stuff right now is gluteal buttock injections. Is there an opportunity to give it in the thigh? Could that people give self-injection? And this is a study of long-acting ART treatment where they looked at optioning people to give it in the anterior thigh. And here's the bottom line. It worked, but people didn't like it. The anterior thigh was only preferred by 30% of people. Apparently it hurts, it gets swollen. The anterior thigh doesn't seem like a popular place. So can you, if you had to, yes. Should you, should it be generalized? Probably not. So that's disappointing, but stay tuned for more. And that's it. Those are the last studies I'm going to talk about, but there was a lot more that was interesting at CROI, but those were my top 6 that I wanted to share with you. Thanks a lot.
Thank you very much, Dr. Landovitz, and all of the presenters. We are running a bit out of time, but we'd like to, if people are willing, to stay for an extra minute or two if people do have questions for any of the presenters. No questions? Okay, then we will again thank you all. I want to remind you to please complete the evaluation using the link that's provided for you in the chat. And also please remember that this webinar has been recorded and that the presentations and the slides will be posted on the CHIPS website shortly, and the information will be emailed to you when it is posted. And again, we thank you all for attending our second In Case You Missed It webinar. Thank you.